Hello, and welcome to today's EACVI webinar on What's New in Nuclear Cardiology. I'm Richard Underwood, and I work as a non-invasive cardiologist and a nuclear physician at Imperial College London and Royal Brompton and Harefield Hospitals in London. Cardiac imaging is now an important subspecialty of cardiology and an essential component of managing many of our patients, particularly those with the most common disease, which is coronary artery disease. Whether you're primarily interested in echocardiography, nuclear cardiology, MRI or CT, technology has advanced rapidly, giving access to both anatomical and functional information with a precision and accuracy that I could only imagine when I was a research fellow. In the next hour, we shall be concentrating on recent advances in nuclear cardiology, particularly pharmacological stress, dynamic imaging of myocardial perfusion, and some of the new traces that take us into more unusual and exciting areas of diagnosis. We shall present cases to illustrate these advances, but we shall be as interactive as possible. You can raise questions and discussion points from the chat function on your webinar interface, and we shall invite your opinion on the cases through multiple choice questions. To present the cases and to initiate the discussion, it's my pleasure to introduce two of the leaders in European cardiac imaging, Dr. Oliver Gempeli from Zurich, Switzerland, and Dr. Alessia Gemelli from Pisa in Italy. Oliver is current chair and Alessia is incoming chair of the EACVI section on nuclear cardiology and CT. And if we manage to pique your interest, we invite you to join us in that section in order to learn and to advance our field together. I also want to thank GE Healthcare, who have provided an educational grant for us to produce this webinar. However, GE have not been involved in the selection or presentation of the cases. So, enough from me. The first case will be presented by Alessia. Over to you, Alessia.
Oh, thank you very much, Richard. It's a really great pleasure for me to be here. And I hope all the participants enjoy this webinar. So let me start with the first case. The case number one is related to a lady of 68 years old. She referred exertional breathless and atypical chest pain, and she's in the waiting list for hip replacement. So she has also asthma and chronic obstructive pulmonary disease in gold stage 3. So she's a very difficult patient to manage in order to check if these symptoms are related to dyspnea, to pulmonary pathology, or to ischemia. The first case that we performed is the examination of blood that is unremarkable, and the rest electrocardiogram was normal, and the echo unfortunately showed a poor acoustic window, probably related to the pulmonary pathology, but apparently she had a normal ejection fraction. So I would like to ask to our attendees, question number one. In this patient, which is the best method now, when you have all these variables regarding this patient, assessing perioperative risk for hip replacement? First, CT coronary angiography, or do you think that no further steps needed, or stress echo, stress myocardial perfusion scintigraphy, or stress MRI?
So you can select the answers from your interface, and the 30-second period is just about closed now. So we can see the answers, Alessia, to guide us. So the answers are as follows. 46% of patients suggested CT coronary angiography. The next most common was stress echo at 31%, just 19% for stress perfusion imaging, and 10% for stress MRI. So how do you feel about that?
Yes, I think that both the participant that answered CT or stress myocardial perfusion scintigraphy answered well, but in this case, due to the fact that according to the guidelines, the risk is in the intermediate high, probably stress myocardial perfusion scintigraphy is better in order to check presence of ischemia. And so which type of test, because she has asthma, she has COPD, and she is not able to perform exercise stress test. So in this case, we can use a new vasodilator, that is the regadenoson one. And this is a vasodilator that is related only to the A2A receptors. So in this case, you can use, because you cannot have a side effect on pulmonary pathology. And which is the correlation and the comparison versus adenosine. This is the first published study about the comparison between adenosine and regadenoson, and it is, you can see here that the half-life of regadenoson in the maintenance of ischemia and of vasodilation is a little bit longer than adenosine. It's very important, because in order to check the side effect, you must know very well this point. The other point is that the affinity for the A2A receptor is very high, so you can use a low dose versus adenosine to obtain the same effect. And the same paper showed the availability of the same ischemia test when you check in this randomized double-blind study the impact of the two different vasodilators versus the patient, and the area of ischemia that you can detect, so the accuracy in detecting ischemia is the same. So you can use regadenoson in order to evaluate ischemia with MPI in this kind of patient. The test is very simple. The time consuming is very poor, because you can inject the same dose in the whole patient, so you cannot check the body weight, you cannot check if there is a liver or renal pathology, and you can inject 400 micrograms in every patient. So you can see here, this is my hands, and these are, she is the lady that we show it in this case. In from 10-20 seconds, you can inject regadenoson. At the end, you must inject 10 milliliters of physiologic solution, saline solution, and then you can see here the injection, and then at the end you can inject the tracer. So it's very simple, but you must monitoring the ECG in order to check, and the symptoms, in order to check if you must inject also aminophylline for reducing the side effect.
Alessia, can I just interrupt you there? We've had a question come in from the audience, and it's from somebody working at the Cleveland Clinic in Abu Dhabi, I think a Dr. Al-Ibaj, and he's asking to emphasize the correct ejection time for the tracer after regadenoson administration. Yes,
so you must inject the regadenoson. After 10 seconds, you must inject 10 milliliters of saline solution, and then at the end you must wait for 10 seconds, and then you must inject the regadenoson. So from the starting point, you must wait 30 seconds first of the injection of the tracer.
Okay, thank you.
And here is the ECG of our lady. So you can see that at the beginning the ECG was completely normal, but at the end of regadenoson there is something that is changed. You can see that there is an ST abnormalities in the anterior wall and the inferior D2, D3, and AVF. So something is changed, and it's very strange because in Italy we use a lot of dipyridamole, and it's not so common to have this type of abnormalities at the end of the test. And probably it's due to the fact that with regadenoson you have a massive vasodilation, so the possibility to induce ischemia is a little bit higher, so you have the Steele phenomenon, and you can have the possibility to check this type of alteration.
So in your experience, Alessia, sorry to interrupt, but what proportion of patients might we see ST segment changes in, presumably a marker of true ischemia?
Probably a huge amount of patients. I think that it's higher than 50%.
Oh, really? Quite high?
Yeah. Okay. And if you analyze the paper on regadenoson, you see that the abnormalities at HEG is higher than in dipyridamole test.
I think it's probably going to be patient population specific, isn't it?
Yes.
I think our experience is probably a little bit less than that, but I guess we have...
Yeah, sure. We use only selected population, so probably in our experience a little bit different due to the fact that our patient is very selected.
Yeah.
And you see that at the end of the test, after 15 minutes, we put the patient into the CZT camera. So we injected generally 145 megabecquerel of tracer of technetium with tetrafosmin or sestamib, and we acquired for 6 minutes. At the end, we injected at rest, and the amount of tracer is at the end, the administrative dose is about 4-5 millisievert. So the amount of dosimetry of the exposure is very, very low in this kind of patient. And here we have the MPI scan acquired after stress and at rest. I would like to put the attention of that in this because at the end we have a multiple choice question. So you see that in the first row you have the stress images, and in the second row rest images. You must compare first versus second one. This is a short axis, and this is vertical and horizontal axis. Stress first and rest second. And here you have the possibility to obtain the bullseye. That is, you can imagine the heart like an umbrella. You open the umbrella, you have the 2D representation of the heart. In the middle there is the apex, septal wall, anterior wall, lateral wall, and inferior wall. You must compare stress versus rest in order to obtain the evaluation of presence or absence of ischemia and so on. I would like to put your attention here and here, 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 in order to answer to the following multiple choice question. And this is question number 2. Which is the best interpretation of these images? No abnormality, scar in the LCX territory, inducible ischemia in the LAD territory, inducible ischemia in the RCA territory, inducible ischemia in 3 vessel territories.
So you've got to help us interpret these images. You can still answer the question. Shall we go quickly back to the images?
Yes, obviously.
While you're thinking about it, but you only have 5 seconds left to answer the question, and then we'll see what everybody thought about it. So thank you everybody for voting, and we've got a large majority of patients selecting number 3, inducible ischemia in the LAD territory. A few with inducible ischemia in 3 vessel territories. What do you think?
I think that probably the attendees are right. We discussed before about the possibility of having ischemia in 3 vessel disease, but I think that our participants are better than us because if you see here, before showing the results of coronary artery disease, I would like to show you that with the MPI SPECT you have the possibility to quantitate the amount of stress defect, rest defect, and the ischemic burden. That is very important according also to the guidelines for the evaluation of the amount of ischemia in order to treat in the best way the patient and to choose the best practice for the follow-up also of the patient. But more than this, you have the possibility also to quantitate function, and you have the possibility to have the evaluation of ejection fraction and of volume. So that is very important also for diagnosis and for prognosis. But at the end, here we have the coronary angiography, and our attendees are right because she has LAD stenosis, only an LAD stenosis, and she was treated with PCI and stenting on LAD.
Successfully, I hope.
Successfully,
Okay.
yes. And so, take-home message and case conclusion. Before surgery, even if in this case you have the possibility to risk stratificate, and it's very important because you can reduce the perioperative risk. So in all patients, when you have symptoms, even if they are not completely typical, but when you have lots of risk factors, we have dyspnea, atypical chest pain, probably it's better to stratify patient. You can choose every techniques you want. In this case, we apply SPECT MPI, but you can choose obviously every technique. But more than this, please pay attention to the fact that you can use also regadenoson in patients with asthma and COPD. It's safe, and you have the possibility to obtain the evaluation of ischemia also in this patient.
Okay, thank you. Well, as someone who works in a heart and lung hospital, we certainly have a lot of patients with very severe airways disease that these new A2A agonist agents seem to be very effective in that setting. I should just emphasize that you do need to be cautious in these patients, but you can get them through, which is interesting. Before we leave the case, Alessio, there's another question which has come in, I think, from a Dr. Andrei Bobrov. Hello, Andrei. He's asked a question, can we use adenosine triphosphate instead of adenosine? Do you have any experience of that or knowledge of that?
I don't have any experience about that. Also because in Italy it's off-label, so we cannot use it. In Italy we use dipyridamole adenosine or regadenoson in some cases. I know that there is a lot of paper published about it, but my experience is very limited only on what I read, and I cannot answer. And I don't know if you can answer it too.
Well, I think it's to my knowledge, it has been used in Japan quite a bit.
Yeah.
And I believe it's rapidly degraded once you inject it to adenosine. So you're really using the same agent, I think.
Yeah.
Any comments on that, Oliver?
No, I don't have much experience than much more than the two of you, but I agree. I think it would be most comparable to adenosine because basically it is it is a substance that is degraded into adenosine. So the working mechanism is the same than adenosine at the end of the day.
Okay. Again, before we leave this case, so there's another question come in, I think, from a Dr. Agnocolin. Forgive me for not pronouncing your name properly, but I'm going from just an email address. You showed in this patient some of the gated images for looking at ejection fraction and so on. And the question concerns systolic versus diastolic dysfunction and echo versus nucleo. What's your impression about, in particular, diastolic function using this technique?
So diastolic function is not SPECT MPI is not the appropriate technique for the evaluation of diastolic function, obviously, because we can check also only if it's maintained, it's normal or it's abnormal. But with the new technique, we have the possibility to check it, and it's very important because in the ischemic cascade, the diastolic function is a little bit before than systolic dysfunction. So in presence of perfusion abnormalities and also of diastolic abnormalities, you can have the possibility to risk stratify better patient and to have another important point for the evaluation of the risk before, for example, coronary angiography, or in order to evaluate multivessel disease, because in patients with multivessel disease you can have a diastolic dysfunction. And you can compare also stress and rest.
And a similar question is here asking about atrial fibrillation. It's a big topic, but what would you say about the accuracy of these measurements in patients with atrial fibrillation?
Accuracy is not very good when you have high degree of the heart rate is not so balanced, while in presence of quite normal atrial fibrillation, the accuracy is a little bit better.
Okay, good. Well, Alessio, thank you very much for taking us through that interesting case. Let's go from Pisa to Zurich, and Oliver, over to you.
Thank you very much, Richard. Hello, everybody. It's a pleasure to be here, and I will be presenting the second case. So let's go straight to the case, which is a 67-year-old gentleman, which was basically doing fine. He was totally asymptomatic and presented for a checkup with his private GP. He had a long-standing type 2 diabetes with retinopathy and neuropathy, right lower limb amputation for osteomyelitis a while ago, but the patient was still moderately physically active with his prosthesis. He also had some chronic kidney impairment, stage 3, with a GFR of 56. And as you can see, quite an extensive cardiovascular risk factor profile, with the diabetes, with some hypertensive disease as well. And he was moderately obese with a BMI of 35, which will be important also for this case. And he was on a medication for his diabetes and his high blood pressure.
Oliver, can I just ask there, BMI 34, sure, that's in the obese category, but in some countries, the average weight of our patients is getting up to BMI 30, isn't it?
Well, we in Switzerland, we're very concerned about health, and for us, this would be already somewhere in the range of mildly obese.
Okay, well, I'm going to move to Zurich.
Say that. So, when he presented to his GP, he did some blood work, which were unremarkable except for the reduced GFR. An exercise ECG, a treadmill test, was not possible because of the prosthesis of the patient, and an echo was not done because the patient was a GP, was not a cardiologist. But the GP still felt that he needed a bit more data with this patient, that the risk was rather high, and he wanted to have some kind of risk assessment, and he sent the patient for a cardiac CT scan. And these are the results of the cardiac CT scan. The calcium score scan showed a very high calcium score of 8,000. You can see there are lots of calcifications here in the left main, the circumflex artery, and the right coronary artery. Probably it's a little bit overestimated because of all these motion artifacts that you see here. So it may actually be a bit lower than 8,000, but it's certainly very high. And this is the contrast-enhanced CT coronary angiogram, which, as you can see, is just really poor quality. So there's lots of calcifications, again, in all the vessels. And you can see that the opacification of the vessel is not very nice. There is some degree, some level of motion artifacts across the right coronary artery, the circumflex artery. It's really difficult to evaluate this scan. And this is what we are left sometimes. We have a scan which is really difficult to interpret. So what shall we do now? And this is the question that we are facing, because we have this asymptomatic patient, and I would like to have your help with this patient now. What would be your next step? Would you say we do nothing since the patient is asymptomatic and is doing generally well? Would you advocate aggressive medical treatment? Would you say we need some additional testing with ischemia? Or would you send the patient straight for invasive coronary angiography?
So, important questions. We've seen a very abnormal CT scan, and now we're possibly committed to doing something else. But let us see what our audience think on that. Well, well done, our audience, because you're aware that we're in a nuclear cardiology session, and so 2/3 of our audience has recommended number 3, ischemia testing. But a substantial minority, invasive coronary angiography, a third recommending straight to invasive angiography. Oliver?
All right, these are interesting results. Of course, I'm happy to hear that some people would suggest to do some ischemia testing. However, I think we need to spend maybe 30 seconds discussing whether this was actually a correct thing to send the patient for a cardiac CT scan who was totally asymptomatic. And this is certainly something that can be discussed, because if you look at the guidelines, recommendation, appropriateness criteria, whatever there is around in imaging, then actually cardiac CT coronary angiography is not an appropriate test in a patient who is totally asymptomatic to screen for coronary artery disease, just because there's no data that has shown that CT coronary angiography actually improves the outcome of asymptomatic patients. What about calcium score scanning? Here again, we use the calcium score for risk assessment in asymptomatic patients, particularly when they are intermediate risk and we're not sure exactly whether we should classify them as high or low risk. But in a diabetic patient, which per se is already at high risk, also the indication to do a coronary calcium score scan is somewhere undetermined or inappropriate. But what happened actually is that the patient got a coronary angiogram. He was sent straight to coronary angiography without any ischemia testing beforehand, and this is the results of the coronary angiogram. You can see that there's a lot of calcifications in the left coronary artery. We have this very high-grade, quite nasty, calcified, ostial 99% circumflex lesion, and you can also see that there is a total occlusion of the right coronary arteries with collaterals coming from the LAD to the right coronary artery here. If you look at the LAD, then there is some degree of disease here in the proximal part, which was considered to be in the range of 20 to 50%, but not more. And finally, this is the right coronary artery here on the left-hand side, which is occluded in the proximal part. And this is the LV angiogram showing only slightly reduced left ventricular ejection fraction with some posterior hypokinesia. So to sum it up, we have an asymptomatic diabetic patient with coronary two-vessel disease involving a chronic occlusion of the right coronary artery and an ostial calcified 99% circumflex lesion, and with a slightly reduced ejection fraction with some posterior hypokinesia. Once again, I'd like your help with managing this patient. What do you think would be the next most appropriate step in this patient? Do you think we just need medical treatment, or do you think the patient should be revascularized either by PCI or by CABG, or do you think we need more information, more data by coronary functional imaging?
So there's the question. It's a slightly tricky one to answer, I think, but we'll welcome your responses on this. I'm well aware that this was an asymptomatic patient and we're going way, way down now the investigation path. But let us see what our audience thinks should happen. Well, we have the answer in, and again, congratulations to the audience, because this is a nuclear cardiology webinar, and over half of our patients would go to ischemia testing of some sort, and about the other half would do some sort of intervention, either PCI or CABG. It's interesting that nobody has said number one.
Yes.
What do you think?
I think that's interesting, yes, and I think it's a difficult question. I'm not sure what is the right answer in this for this question, because the most important concern is that the patient is really asymptomatic. So whatever you do, you're not going to improve any of the symptoms of the patients. We are just merely concerned about the prognosis of the patient, and this is what will drive our decision to do either some revascularization or some medical treatment. And this is why this is, I think, a particular difficult question. CABG, for example, sending the patient into open heart surgery who is basically doing fine and asymptomatic, I think is always a very difficult step, and it's very difficult to convince a patient that he will need such a heavy surgery if he's doing so fine. So it's a difficult question, but I'm happy, of course, to hear that some people would consider functional imaging, because this is also what we did. We felt that just based on the coronary anatomy, which shows two-vessel disease without involvement of the proximal LAD, that the situation is not that clear, because this anatomy is per se not considered very high risk, and we just wanted a bit more information to be able to stratify the risk of the patient more appropriately. And this is why we decided for additional imaging for ischemia testing.
So, Oliver, can I just ask, you've obviously got an occluded right. You've got a, what was it, 99% circumflex?
Yes, 99.
So you can't be in any doubt that those are going to be functionally significant. So in prognostic terms, do you feel that looking at perfusion gives you prognostic information over and above that anatomy?
Yeah, I think this is the feeling that probably you will get some additional information over the pure anatomical information. We know that ischemia testing in patients, in stable coronary artery disease patients, is one of the most potent predictors of outcome, actually, particularly if ejection fraction is normal. And this is the case we have in this patient. And although it looks all to be very tight, and we also have a chronic occlusion, I think it's nice to have in your hands some objective criteria of ischemia that you can show to the patient and tell him, look, you have ischemia or you have no ischemia, and this is why we would suggest to do either revascularization, or we can go for medical treatment.
And we do have a question from Dr. Addy in Hull in the UK, who's asking, what risk would you quote to this patient of invasive angiography?
You mean the risk of invasive angiography?
The risk of the procedure itself.
Or of PCI?
No, of
Just
the procedure, of the diagnostic angiography.
Well, I think nowadays invasive angiography is quite a safe method. Obviously, it's an invasive test, and you are always concerned about the risks of invasive testing. But with current techniques, the risks are always very low. You have generally a risk which is way lower than 1% for really serious complications like stroke, MI, or death for these, purely elective diagnostic procedures. Obviously, you have some risk of bleeding, which is also in the range of lower than 1%. But I think nowadays we are really talking about quite a safe invasive technique.
So anyway, you went along with the majority and went for number 4.
We went for number 4. And now I have again the next question, which is, which kind of coronary functional imaging would you suggest for this patient? Remember, it's a diabetic patient. He's slightly obese with a BMI of 35. So and he cannot exercise because he has a limb prosthesis. So what kind of stress test would be appropriate? Would you go for myocardial perfusion SPECT, or shall we do magnetic resonance imaging? Shall we do a myocardial perfusion PET, or stress echocardiography?
Okay, well, the question was open all the time you were speaking, so we have the results in. And as I might have guessed, it's a fairly even split, but the majority are saying, they're trying to be nice to us, Oliver. They're saying myocardial perfusion SPECT, okay? The next most common in 53% saying that, 16% wanted to do a stress echo, 18% perfusion PET, and 13% MRI. Okay,
that's very nice. I think people are slightly biased because they know that they are watching a nuclear webinar, but I think it's good to hear that some people would suggest radionuclide techniques. And I can tell you what we did. I think there's no right or wrong answer here. I think the choice of technique depends on many factors, mainly availability, mainly the expertise for one or the other technique. So there's really no right or wrong. I can tell you what we did in our institution. We did an ammonia PET. And the reason why we performed ammonia PET is because, first of all, we have good experience with this technique, particularly in obese patients or slightly obese patients, because it provides slightly better image quality than, for example, SPECT or echocardiography, which can also be a problem in patients who are a little bit on the overweight side. So these are the images that I would like you to study carefully, because there's going to be a question later on about the results of this test. So again, you have the stress and the rest images, one above the other, short axis slices, vertical long axis slices, horizontal long axis slices, and some selected short axis slices here. Now, we can also do polar maps. You saw them before in the case that was presented by Alessia. These polar maps show you basically the entire heart at stress and at rest. And there's also some information from gated PET showing volumes and ejection fraction at stress and at rest. And finally, I think an important thing that distinguishes PET also from other techniques like SPECT is that we are able with PET to quantify myocardial blood flow in absolute terms in milliliters per gram per minute for each single coronary artery territory. You can see that in this case the patient had stress blood flows in the range of 0.7 to 1.2. And at rest it was in the range of 0.7 to 0.8, and then we can calculate the myocardial perfusion reserve, which is the ratio of stress over rest myocardial blood flow.
Oliver, what values would you expect in normal patients, stress and rest?
So a healthy normal volunteer should be able to have a hyperemic blood flow, so at stress, of more than 2 to 2.5 milliliters per gram per minute. So you can see that here this is clearly below this threshold. Okay, so please help me with interpreting these images. What are we seeing? Do you see a fixed anterolateral perfusion defect, large partially reversible infralateral perfusion defect, a normal myocardial perfusion reserve, inferolateral attenuation artifact, or normal post-stress ejection fraction? What is the correct answer?
And we can go quickly back to the images while you're thinking about that.
Maybe we show these ones here.
Yeah. So have a look at the pictures. It's a slightly complex set of options there, but I hope you're able to interpret those images. And the voting is now closed. And Oliver, the majority, 53%, are saying number 2, a large, partially reversible infralateral perfusion defect.
Very happy to hear that.
A third of us have said a fixed anterolateral perfusion defect, and smaller numbers saying the others.
Okay, so I agree with the majority. We see clearly something in the infralateral wall, which is mainly reversible, which increases in size with stress. That means there is probably some sort of scar already, but with some significant peri-infarct ischemia there. We also see that the anterolateral wall is not normal. There is a normal perfusion at rest, but some reduced perfusion with stress. So there's also a large amount of ischemia in the anterolateral wall.
So the option there that I think might have misled people is the option was a fixed defect in the anterolateral region, which it's not.
The defect in the anterolateral region, as we can see, is clearly not fixed. It is reversible, which means we see it with stress, but not with rest, and that's the hallmark of ischemia, of course.
Thank you.
Okay, so we move on to basically the management of the patient. Based on this scan, on this perfusion scan, the patient was actually then selected for CABG, for surgical revascularization. With grafting of all the 3 vessels. There was a Lima graft on the LAD, radial graft on the circumflex, and the right mammary graft on the posterior descending artery of the right coronary artery. Then there was a very complicated postoperative course with lots of complication, and this is again why I think that sometimes it's difficult and problematic to operate on asymptomatic patients without any objective proof of ischemia, because you're going to submit the patient to potentially a lot of complications, which sometimes can happen with CABG surgery, who was formerly totally asymptomatic, and the patient will really ask yourself and himself whether it was all worth the pain. And finally, the patient was discharged on the day before Christmas after 3 weeks.
So that was a good Christmas present for him.
Absolutely.
But just before you move on there, Oliver, so a Lima was put on the LAD.
Yeah.
Okay, now there's a little bit of a discrepancy here, isn't there? Because the angiogram was not so exciting in the LAD territory, but the perfusion scan was. What do you say about that discrepancy?
Yes, you're absolutely right. That was also discussion with the surgeons whether they should graft the LAD or not. And based on the perfusion scan, it's not totally clear whether the LAD has a problem. And you are totally right. If we look at the angiogram, there was only a 20 to 50% proximal LAD stenosis, but we all know that the visual quantification of stenosis degree is not very good in predicting the hemodynamic relevance, and this is possibly one of the cases where we actually underestimated it visually, and in fact it is a significant lesion because, and this is probably where we have some added value of the quantification, we can see that myocardial perfusion reserve and hyperemic myocardial blood flow here in the LAD territory is clearly reduced, is below the threshold of 2 milliliters per gram per minute. So there's something abnormal there going on, and although we cannot really say whether this is microvascular disease or it's really due to the stenosis of the LAD, we can say that it's not normal, and that was reason enough for the surgeons to say, okay, no, let's put an LAD, let's put a Lima graft also on this LAD if we're not sure whether it's significant or not.
Yeah. Okay. Thank you.
So, if I may, I would just like to summarize a few conclusions of this case. I hope that I could show that myocardial perfusion PET is a good alternative to myocardial perfusion SPECT, particularly in obese patients, because it provides a slightly better image quality than at least conventional myocardial perfusion SPECT. Another advantage of PET over SPECT is that it also allows absolute quantification of myocardial blood flow in milliliters per gram per minute, which, as you can see from this example, sometimes can add some information and add some clinical value to the case. But keep in mind that PET clearly is less widely available than SPECT, and in some cases you will need an on-site cyclotron to produce the tracer, which in our case was ammonia. You can also perform perfusion PET with other tracers like rubidium, which are not dependent on an on-site cyclotron, but if you're doing ammonia, you will need an on-site cyclotron.
Okay, we've got another question from the audience, and actually I think I'm going to answer this myself because it's from Dr. Luc de Boucalier. Sorry, Luc, if I don't pronounce you correctly, from Belgium, and he's asking about dual energy perfusion CT and what the role of that might be alongside these other techniques we've been talking about. And I think the answer to that, Luc, is that you should attend the webinar on Thursday the 22nd of March next week, because we have another webinar precisely on this topic. So we look forward to seeing you there. Good, thank you. So Oliver, that's your case, yes?
Yes.
Right. Well, we've got 10 minutes or so left.
Yes.
Alessia, what's in store for us next?
I would like to put the attention of the audience on the possibility to use nuclear cardiology for helping cardiologists in the evaluation of cardiac amyloidosis. When I start to study medicine, cardiac amyloidosis was considered a rare pathology, and I think that no one can have the possibility to perform a diagnosis of cardiac amyloidosis without myocardial biopsy. And so the possibility was very, very low. Up to now, we have the possibility to change the evaluation of cardiac amyloidosis, also because we start to increase the number of patients with this pathology. And why? So you know that we have two different kinds of amyloidosis, AL amyloidosis and TTR amyloidosis, that are completely different because the way of developing the amyloid is completely different. AL amyloidosis is starting from cell dyscrasia, while the TTR amyloidosis is generally senile pathology and is due to a wild-type gene. So due to this fact, the possibility to diagnose is completely different. But with nuclear medicine, we have the possibility to evaluate these two types of amyloid in the same with very simple method and very easy. So start with the first case. The first case is a man of 82 years old that come to our attention for dyspnea, vertigo, and hypertension. This is the HEG of the patient that is very typical for amyloidosis. You see here that there is low voltage of all the HEG, and it's very, very typical. So you have the suspicion of this pathology. When you perform the baseline echo, you see that the ejection fraction is normal, and it's very typical because the first change is not on systolic function, but is on diastolic function, because there is the amyloid is the deposit of amyloid is in the between the myofibril, so you have an increase of the thickness of the walls of the myocardium. So diastolic dysfunction is the first change, as well as the right ventricle. That is, there is a poor function of right ventricle. For this reason, the first symptoms is dyspnea, like in this patient. And you see that there is a huge increase of NT-proBNP as well as of troponin. Here we have the MRI, so you see diastolic and systolic function, late gadolinium enhancement, and you have the possibility to observe that the suspicion is increasing, but you cannot obtain the diagnosis for this with this MRI, because it's not really interpretable in terms of amyloidosis. So with this flow chart, you see that in case of absence of real diagnosis, absence of cell plasma dyscrasia, you can perform in a very simple way a bone scintigraphy with technetium. And you see here, this is a normal scan obtained with the injection of technetium plus DPD. We generally perform this type of scintigraphy in oncological patients for the evaluation of metastasis. This is a normal scan, no metastasis, normal scan. Here, there is the scan of the patient that we presented in this case, and you see that there is a huge amount of tracer, of the uptake of the tracer in the heart. This is a very simple way to perform diagnosis of TTR amyloidosis. But more interesting, with the CZT camera, we can have the evaluation of regional uptake of amyloidosis. And you see that it is very diffuse. It's not only regional, but is in the whole ventricle. It's a very interesting case.
So Alessia, that's an important point, isn't it? Because the MRI looked quite regional in terms of the scarring from late gadolinium enhancement, but this is showing up something much more diffuse.
Yes, yes. Probably with this type of tracer, we have the possibility to detect very well the deposit of the amyloid, because this tracer is depending on the amount of calcium. And due to the fact that TTR amyloidosis is the compound of TTR amyloidosis is rich of calcium, you have the possibility to detect that. But go to another type of case. AL amyloidosis. So you see that here we have a completely different kind of patient. She's a female of 68 years old, and she arrived to our attention for exertional double breathlessness of recent onset. And you see here that NT-proBNP is not so high, as well as troponin. While this is the echo of the patient, you see here that there is the thickness of the wall are very, very increased. And another problem is that here you have an increase of plasma dyscrasia. So like in the previous flow chart, in order to perform the real diagnosis of cardiac amyloidosis, you should perform biopsy. But it's not so common. It's the risk and the side effects are very high. So Probably in the future. Now it's only for research because the tracer up to now are available only for the evaluation of the presence of amyloidosis in the brain. We can use also for the evaluation on the heart. But I would like to show you this patient, how is diffuse the deposit of amyloid, not only in the brain, here, but also in the heart, in the lung, and in the abdomen. So amyloid is really diffuse, and in this patient you see how is high the amount of the tracer in the heart. But more
so
than this,
a normal scan using this agent in the brain would have no uptake?
No uptake.
Okay.
No
And just going back to the previous picture again, I'm sorry, Alessia.
Yeah.
I'm interested in the bowel uptake, because that is that just excretion of the tracer, or is there actually amyloid in the bowel there?
Is amyloid.
Yeah.
And here you have the possibility to 3D reconstruction of the amount of the amyloid in the heart. And here you have the fusion between CT and PET for the evaluation of the amyloid in the left ventricle. You see how it's diffuse. This is only for research up to now, but is the possibility that we have with nuclear medicine to perform diagnosis in terms of evaluation of amyloidosis. And I think that we can help in a very simple way, very repeatable. All of patients can be submitted to this type of investigation. And so I think that it could be one topic for nuclear cardiology in the future.
And can I ask a little bit about treatment? I mean, does the uptake of this agent in the myocardium give you any hint of what sort of treatment and whether they will respond to it?
Yes, the treatment is not so changing because you know that the prognosis of this patient are not very good, but the possibility to detect in the at the very beginning of the pathology probably can change the way of treatment, because here we have the possibility to evaluate only at the end. But probably if we will be able in the future to detect some variables in order to evaluate in the previous step this type of pathology, probably we can change the way of treatment and we can improve the prognosis of this patient.
And I was interested in the two patients that you showed, the difference in the BNP levels. The TTR patient was very high BNP, presumably implying worse heart failure?
Yes, probably.
Or do you think that, is that specific to the different types of amyloid, the way they affect left ventricular function?
I don't know exactly, but generally in old patient, the amount of NT-proBNP is higher than in young patient, and probably it depends on the evaluation of the right ventricle. In the first patient, right ventricle, there is a poor function of right ventricle, while in this patient the function is well preserved. So probably right ventricle should be more evaluated and better evaluated in this kind of patient.
Okay, thank you. We do have a couple of questions from the audience as well on this. They're not specifically on amyloid, but while we're talking about these myocardial problems, we've been asked about both sarcoid and infection, myocarditis, endocarditis. What can you say anything about the role of nuclear cardiology in these important areas?
Oh yes, regarding sarcoidosis, I think that Pat and Oliver can spend more words about that, have a very important role, as well as in endocarditis. Regarding endocarditis, we published a paper with the ENM about the importance of the use of nuclear cardiology in the evaluation of endocarditis, and also on sarcoidosis there is a lot of paper that underline the importance of the PET with FDG for the evaluation of sarcoidosis.
Okay. Oliver, this has been the subject of another webinar, am I right?
Yes, I think you mentioned two very important topics, and obviously we felt they were so important that there have been two webinars dealing with these two issues. One issue, the issue of infective endocarditis and nuclear cardiology, and the other topic was generally nuclear imaging in patients with myocardial inflammatory disease. And I think Alessia already mentioned the most important things about it, but I can just repeat what you said. Both fields are important fields for nuclear cardiology. For infective endocarditis, we actually now have PET-CT in the guidelines, or SPECT-CT in the guidelines, to help with the detection of endocarditis, particularly in patients with prosthetic valve endocarditis, which are sometimes difficult to assess just with echocardiography, even with transesophageal echocardiography. And sarcoid is another topic. FDG PET is a very sensitive technique to detect the cardiac involvement of sarcoidosis. And it can also be used to track disease activity with steroid treatment. So I think both are very important areas that nowadays deserve a lot of attention, and where nuclear cardiology plays an important role nowadays.
Okay, thank you. So we're coming close to an end, but I'm just going to allow one more question from the audience, and it'll bring us back to amyloidosis, because I feel we went over MRI rather quickly, and I think most of these patients would have an MRI scan, and you were slightly negative about MRI. Am I being fair?
No, absolutely not, absolutely not. But not all the patient can perform MRI, and not in all patients MRI can be able to perform diagnosis. While nuclear medicine can give a yes or no question. Yes or no answer. So in presence of, for example, TTR amyloidosis, presence of uptake is you can perform diagnosis. While with the MRI, in some cases, so the accuracy is not so high, and probably not all the patient can perform MRI. In our institute, we use MRI for the evaluation. You see, in all patients we perform MRI, we check in all patients. So I use it, but I think that in general, for general purpose, probably nuclear medicine can give a better answer, because it's very simple.
Okay.
It's you can inject the tracer and you can obtain a picture. Yes
so
or
I
no?
think you're
So
emphasizing simplicity and specificity.
yes, and availability probably.
Okay. Okay. Good. Well, thank you very much, Alessia. Oliver. So I'm afraid that we're now approaching the end of the webinar, and I'd like to close by reminding us of some of the key messages for your daily practice. First, many patients are unable to exercise maximally for a full assessment of coronary function. Myocardial perfusion scintigraphy has the unique ability of being able to image myocardial perfusion both during exercise and with pharmacological stress. However, many patients have comorbidities that preclude stress agents such as dipyridamole and adenosine. But the availability of specific A2A adenosine receptor agonists such as regadenoson, which we've discussed, now make it much easier to stress even patients with quite severe airways disease. Secondly, dynamic imaging using PET tracers such as ammonia or rubidium provide not only high quality qualitative images of perfusion, but also quantification of perfusion in mils per gram per minute, which gives valuable information, additional information, particularly in patients with extensive three-vessel disease or possible microvascular disease. If you don't already have access to PET perfusion imaging, it's possible that dynamic SPECT imaging using a solid-state camera will provide similar information, but that still requires further validation. Finally, cardiac amyloid is an under-recognized cause of heart failure, and it can be difficult to spot. However, radionuclide imaging using good old-fashioned bone tracers is sensitive for detecting TTR amyloid, and new PET agents also have a role for AL amyloid. So, let me close by thanking Dr. Alessia Gemelli, Dr. Oliver Gempeli for their presentations and discussion. Thank you to GE Healthcare for their educational grant. Most of all, thank you to you for your participation and valuable questions and discussion. You will be able to view the webinar offline in a few days, and we look forward to seeing you at the next EACVI webinar on Thursday the 22nd of March, where the topic will be the assessment of coronary function by CT. Goodbye.